Thank you for Japan. First of all, I want to express the heartfelt thanks to the organizers for giving me this opportunity to participate in such an exciting conference. So today I want to show our update finding on the metabolic resilience. So this is a typical representative scheme of the life course in the individual elderly. So as the previous speaker mentioned, the several clinical, so elderly people sequentially suffer several clinical events, and they display the gradual decline of their daily activity. So this is due to the impaired resilience, reserved capacity. So young people can recover quickly in any chance after the stress, but in aged or frailty people display the impaired resilience, so they cannot come back to the basal level. So resilience is frequently initially described in the social science or the psychological neurology. So people always pick up this word. But nowadays, we notice the resilience is also the key to understand the aging. So they call, for example, in this EMBO paper, they describe tissue resilience. And the key factor which can impair the resilience is now we notice this kind of senescent cells accumulating in our body, because this displays the quite secretory phenotype called SASP and impairing the neighboring tissue physiological function. So this is a summary of the senotherapy which are now proposed. So there are two parts. One is senostatics, mainly suppressing the SASP phenotype, and the other is senolysis, the termination of the senescent cells. So today I want to talk about both approaches in our laboratory. So now the historical aging theory, calorie restriction could be explained by its senostatics functions. So there are several key players identified in the calorie restriction pathway, such as intokinase or AMP kinase. Their outcome is also now clarified. FOXO activation resulting in the reduction of the oxidative stress, or PGC1 activation can boost the mitochondrial genesis. And these key players are also activated by several metabolites. So we started human metabolism work about 15 years ago. There are thousands of metabolites in the cells or in your body, and by using the LCMS, we can comprehensively analyze this profile called metabolome. So in collaboration with Professor Yanagida, we try to develop our unique approach to identify the human metabolite. We call it the whole blood metabolome. Because 1/3 of metabolites are quite labile, so we try to make them stable. So finally, we notice whole blood quenching is most straightforward to make the metabolite stable. And using this technology, we try to investigate several aging-relevant cases. So first, we assigned about 130 metabolites, and this is a summary of the CV value. So here, the upper panel showing the quite low CV value. That means they are very stable. and the lower one is showing the quite higher CV values. That means they are quite variable from individual to individual. So if you look at these metabolites with higher CV value from diet or here is caffeine, but anyway. So in this setting, we started the first aging biomarker investigation. So this is a summary. So there is a 30 healthy participants, and half is very young and half is very old. And according to these conditions, we identified 15 aging markers. So 9 metabolites are decreased in elderly and 5 are increased. So you know most of the metabolites decreased in elderly is antioxidative metabolites. And on the other hand, the upregulated metabolites are somehow involved in kidney impairment. Next, we applied this technology to detect the frailty biomarkers. As you know, frailty is defined as a vulnerable state to any kind of stress. And now these frailty people are increasing in the world. Here is an interesting report in eLife. So they investigate about 300 elderly for 20 years by checking the 9 different aging markers. There is methylation or telomere length or cognitive function, and here is a frail index. And the conclusion is they notice frail index is most predictive marker for the elderly mortality. In this way, this paper concluded that frailty reflects the human aging. So we try to pick up the patient in my clinics. So all patients are over 80 years old or so. So the average is very old, 84 years old, and half are frailty and half are no frailty. So we applied Edmonton frailty scale here to diagnose the frailty score. And this is the result. We identified 15 frailty marker among the 129 metabolites, and half decline of the antioxidative metabolites. So carcinogenesis, ergothioneine, oxamic acid, urate, they all show the decrease in the frailty people compared to the control non-frailty people. And here is a heat map. And strikingly, if we use these biomarkers for the diagnosis, here is a PCA plot, we can nicely dissect the patients from frailty to the other. So in this way, our frailty metabolites are quite a strong candidate. So we reported these results in 2020. At that point, there are 5 other reports on the frailty metabolites. But we are the only group who reported the anti-oxidative metabolite is essential in frailty. So the reviewer always asking, so we're trying to explain. So here is a summary of all reports on frailty metabolites. And the point is we utilize the whole blood metabolome approach. And we also use the EFS as a diagnostic tool. So here is some evidence. So this is a summary of the frailty metabolite which we identified, and half of them are RBC-enriched metabolite. this red sign shows RBC-enriched metabolite. So we reason this could be the reason why we can detect these anti-oxidative metabolites, because we're using the whole blood metabolome approach. So to make the long story short, we also identify the sarcopenia biometabolite in the same group. So clinically, we always notice the frailty and sarcopenia is much overlapping symptoms, clinical entity. But here, if we look at the metabolites, they are completely different. So there are many sarcopenia markers comprises the, let's say, muscle or mitochondrial metabolites are decreased. But here in frailty case, half of the metabolites antioxidants decline. So in this way, we performed about, let's say, 15 years metabolome analysis. And this is a summary of our works. And you see there are some overlapping in the antioxidant metabolites or the BCA metabolites in the several entities, frailty or fasting. So we believe these metabolites are key to understand the human aging. Additionally, sorry in Japanese, but we established the convenient diagnostic tool as an appli. So this is a Kyoto frailty score. So if you use this appli, so just 30 seconds, they will tell you whether you are frail or not. So this is quite convenient to detect any frailty people in the local area. So in the latter part, I would like to talk about PGAM. So PGAM is one of the glycolytic enzymes, and it's located here. It converts the 3-phosphoglycerate into 2-phosphoglycerate. So we're working for this glycolytic over 25 years, and we published several stories. PGM is ubiquitinated. PGM is much involved in the T cell immunology, and here also PGM is involved in the pancreatic cancer growth. Most recently, we noticed the non-enzymatic role of PGM. So in any standard cells, PGM functions glycolytic enzyme, but in cancer cells, as you know, due to the Warburg effect, the excess of PGM exists. And these PGM can bind to the CHEK1 kinase to boost glycolysis. In this way, this complex supporting the Warburg effect. And if we interfere this binding, we can suppress the Warburg effect. So this is a non-enzymatic function of PGM, because PGM enzymatic activity is quite intact even after inhibition of these binding. And recently, we notice even in the senescent cells, similar events happening. So here is genetic tools to induce the cellular senescence by the tamoxifen. So here is a nice fried egg structure, and you see the senescent markers here. And we noticed in these senescent cells, glycolytic flux is upregulated compared to the young control. And in this setting, we notice the PGM CHEK1 binding is much enhanced in senescent cells. So we concluded this PGM CHEK1 binding can support the glycolytic activity, and this is a common feature in cancer and senescent cells. So based on these findings, we try to identify the PGM check-1 binding inhibitor. So 2016, Promega invented this small nano-look. So this is half size than conventional luciferase, but luminescent signal is over 100 folds. So they split them into large portion and small portion, and once they combined, you get a signal. So they call this system nanobit system. So using this system in collaboration with Promega, we established the PGM check-1 nanobit system to perform the high throughput screening to identify the PGM check-1 binding inhibitor. So here is senolytic. Finally, we got some senolytic compounds which can inhibit the PGM check-1 binding. So among them, today we can show the one candidate, drug Z. So drug Z can efficiently inhibit PGM check-1 binding in the dosage-dependent manner. And here you see the green signal stands for the 2-NBDG. This is a glucose analog uptake. So senescent cells showing much more green signals here because they are glycolytic. But if we treat these cells by drug Z, they show the decrease of the green signal. That is suppression of the glycolysis. And strikingly, the drug Z can selectively eliminate the senescent cells like the ABT263. So this drug is also functional in vivo. So if we treat the old mouse by these drugs, there are several physiological markers is improved, alleviated, and also the chronic inflammation. Here is macrophage accumulation in the aged liver, but after treatment by our senolysis, this macrophage is much suppressed, and the SASP phenotype also downregulated. So in the former parts, Kameda-kun did a lot for the metabolite identification, and in the latter part, Mika-kun do his works to identify the senolytic drugs. Thank you for attention.
Questions? So Hiroshi, in your first talk, when you are identifying the metabolites, so most of them are amino acids you are getting into it. Amino acids, right? The metabolites which were screened for it. So in the 80 plus years, so is it the synthesis is the problem or the uptake is the problem in the aged patients?
So this is a list of the metabolites which we assign. So not only amino acids, any purine, pyrimidine, or there are less lipid, but any bioactive metabolites are also included.
So how they are variant in the population? Is it there is any standard for it, or is it roughly up or down? Like say that statistically how they are differ in this ones.
Okay, so the most prominently among amino acids, leucine, isoleucine is downregulated in the elderly or frailty people, but this is well known in the previous literature. But anyway, in our hands, we confirm this BCAA is a key in aging phenomena.
So the synthesis goes down basically.
That's, well,
because sometimes it can be uptake also lower. Or recycling of the leucine from the lysosomes are also lower.
We don't know.
Okay.
Yeah, sorry, we don't know.
Oh, there is one more question.
Hi. You didn't see me. I have a small question, maybe a comment on what you find on the markers. There is this signature of antioxidative pathways, but every time there's a redox reaction somewhere that produces electrons, you have protons as well, and you mentioned that quickly in the Warburg effect, so that there is probably an interplay also with acidosis. So do you have evidences that there can be modification of genes or proteins that are also involved in production of acid-base equivalents or pH regulation that go with the oxidation as well?
Okay, that's a good question. But so we simply perform the metabolomic approach, so we don't have any other omics data. So we don't know it's due to the synthesis or degradation, or we don't know. We don't have the answer for that.
Oh, thank you, Hiroshi. Thank you.